Welcome. Happy Monday, everybody. I'd like to welcome you to our webinar today, which is part of a 4-webinar series sponsored by the National Academy of Sciences, Engineering, and Medicine. I'd like to start by thanking the NIH Office of Dietary Supplements, in particular, Nancy Pottishman and Jamie Gausch, for sponsoring this webinar series. I'd also like to thank and acknowledge the Program Planning Committee that included Doctors Cheryl Anderson, Donna Dablia, Stephen Daniels, Asa Matthias Davis, Erica Gunderson, myself, Lisa Harnick, Amy Herring, and Ana Maria Ciega Reyes. You will be hearing from these committee members throughout the seminar. There will be a couple periods of Q&A time where committee members will be asking the speakers questions. I said this is one of 4 webinars. The first webinar was held 2 weeks ago on methods for assessing dietary intake during pregnancy. Later this week, there's a seminar on assessing diet in children 6 to 11. And then next week, the webinar will look at innovations and special considerations in assessing dietary intake during pregnancy in ages 2 to 11. To learn more about these webinars, go to the National Academy of Sciences website. The recordings of all of these webinars will also be available there. And the pregnancy one is, I believe, already available for viewing if you missed that one and you want to hear that. We have a full agenda today, a packed 2 hours. We're going to start with me getting you oriented to thinking about children ages 2 to 5, and then move on to Dr. Susan Johnson from the University of Colorado, then Dr. Linda Van Horn. We will take a 15-minute Q&A break for the committee members to ask questions of those speakers. We'll take a short 5-minute break for you to stretch your legs, and then we'll jump back in to talk about lessons from the Feeding Infants and Toddlers study on assessing diet presented by Dr. Andrea Anitar from RTI, Research Triangle Institute. And then Dr. Nicholas Horton from Amherst College will talk. And there'll be another 15-minute Q&A period with the committee members asking questions. And then we're going to open it up to all of you to ask your questions. We'll have a panel discussion with all of the speakers, and you will be able to ask questions through the Q&A feature in Zoom. And then I have a wrap up and we'll adjourn by noon Eastern Standard Time. So I'm going to kick it off here, just getting you thinking about children ages 2 to 5 years of age. This is a really fun age of childhood. These children in this age range are growing rapidly. Their gross and fine motor skills are really evolving, and so is their cognitive development. Their eating habits are, this is a time period when children are establishing their food preferences. Kids in this age range can go through eating jags where they eat a limited set of foods for a period of time and then they switch it up a few weeks later and may go on another eating jag. They eat frequently, a lot of meals and snacks throughout the day with usually small portions relative to what older children and adults eat. They are obviously fed by the adults in their household, the family eating a lot of meals at home, but about 80% of US children ages 2 to 4 are actually in the care of others for part of their day. And so they're eating meals outside the home, fed by others. And about 60% of US children are in daycare or preschool settings for part of their day. About 15% are in another person's home or maybe receiving care in their home through a relative or someone like, say, a nanny. And then obviously by the age of 5, unless a child is homeschooled, they're in a school setting. And so eating meals outside the home. And so, so one thing the speakers are going to talk about today is that for children this age range, they do not have the cognitive ability to tell you what they ate or to record what they ate. So we've got to rely on the people who are feeding the children. And so the primary respondent is usually the caregiver most responsible for feeding the child. And then you're going to be learning today about, well, how do we assess eating and drinking while the child is in the care of others? And this certainly gets tricky, but there's a few different ways it can be done. For example, in a study that I carried out a few years ago in a Head Start center, we really wanted to know what kids were eating for lunch at the Head Start center. And so we actually had observers observe the children eating and record that way. So you actually see some adults standing at the perimeter of the room here, and they're recording, keeping track of what the children are eating. Another thing you're going to hear about this morning in the webinar is you've got to be ready to assess the types and amounts of foods eaten by this age range. They tend to eat smaller portions than older children or adults, and they eat different kinds of foods too. So I'm going to wrap it up there and turn it over to our first speaker, Dr. Susan Johnson from the University of California. Welcome, Susan.
Good morning, all. And I'm in the process of getting that screen shared with the first slide. And I have the privilege today of talking to you about a number of different ways to try to assess dietary intake in young children. As Linda already mentioned, some of the considerations for how you do that, because they're young and they can't tell you what they've eaten over a period, is you have to use a proxy reporter to do that. And sometimes more than one. Some of these children only eat one meal consistently with their family, particularly if they're going to childcare for any part of the day. There are considerations related to literacy, both with respect to general reading and writing ability, but also food literacy and health literacy, and their facility with being able to use technology to help them tell you what they've eaten. There are accessibility issues for those who have visual and hearing impairments or cognitive impairments, and language, particularly in the clinical setting. You have to consider what that intermediary of a translator may be adding or not adding when they're telling you about what kids are eating. And all these relate to the costs of collecting dietary intake in young children. Where I'd like to start is thinking about what your question of interest is. Are you interested in total intake? Are you interested in variability across different eating occasions, like holidays or weekends versus weekdays? Is it an interest of a particular setting, what they eat at home versus what they eat out? Or perhaps you are particularly interested in what they eat in the care of others and how that contrasts with what they eat when they're with their family. What level of detail do you want to know about? Are you interested in nutrients from foods and or the supplements that may be adding to the nutrient quality of what they're ingesting? And perhaps it's not only the nutrients that you're interested in looking at. Perhaps you're interested in looking at specific eating behaviors like neophobia or selective eating, and the social and environmental influences on how children are eating as well as what they're eating. So all that to sort of set us up to think about the different kinds of assessments. As Linda mentioned, there are group settings that are considered. There are individual settings. Are you interested in concordance, for example, between what mothers and children eat, or perhaps that peer-to-peer concordance? Considering what the level of specificity that is needed in terms of dietary intake to answer your particular question of interest are all things that should be considered before you choose a specific dietary method. The first thing I'd like to do is to orient you towards an incredibly important primer that's already out there on the web from the National Cancer Institute. I'm not going to talk about the details of this, but before you begin collecting any dietary instrument or information, I encourage you to go to this website and look through the different pieces of information that are available that help you think about how to set it up, what you'll actually get from it reliably, and also thoughts about analysis for dietary intake. And this is not just for young children, but it does help you think through which methods will be the best for your question. Now I'll go into a few more details about specific dietary methods. I'm not going to be able to go through every single piece of information that's on the slide that I'm about to show you, but they're all set up in pretty much the same way. Thinking about what the advantages of a particular method are, which kinds of questions they can answer, what some of the difficulties are, because each of the methods has difficulties, and which kind of data collection can be matched to the kind of cohort or individual that you're interested in assessing. First, let's talk a little bit about 24-hour recalls, which can be done in a variety of different ways. They can be interviewer assisted, where a trained individual asks the potential participant to go back through the last 24 hours of what their child has eaten. Alternatively, it can also be done in an automated format using technology, where the participant goes through a rigorous set of questions that helps to collect 24-hour recall information for their child for the previous day. Pros of this is that those automated methods or the tailored method where you use an interviewer can be translated. One thing to consider, however, is in that translation, it's not just about the language for the words. It also has to match up to the foods that are in the database that are culturally specific that go along with that language. Access to the ASA 24, for example, is free, but that doesn't mean that it's completely free. It still requires certain staffing costs. What are some of the drawbacks or difficulties encountered with 24-hour recalls is that you have to be able to recall what it is that your child has eaten. And that can be challenging sometimes, particularly as Lisa mentioned, that there are multiple caregivers. So your child may not have eaten everything in your presence, and they eat such small amounts of lots of different things many times a day, and that can be a difficulty encountered. The good news is that they can work well with large cohorts, and they can be combined with other methods that I'm going to talk a little bit more about next. What parents tell us, this is some work that Tracy Beckelman at University of Colorado obtained for us, is that it does take time, but it's only time once a day, and that's a positive thing. That the structure and repetition of the ASA 24 protocol in particular makes it easier because it makes it easier to recall and to go through the day. But here's the challenge. You can't recall something that you never knew. If your child is eating away from home, it's a guesstimate at best, and that makes capturing very accurate information quite challenging unless, as Lisa mentioned, you are able to go into childcare and do the same thing with an additional proxy caregiver. Let's move on to food diaries. Food diaries are similar to 24-hour recalls in that they try to capture everything that a child has eaten in a day. They can be done with or without technology, and you can use things like texting to help participants remember to complete these. You can also do things like add photos to assist in determining the estimates of portions that are being consumed. We used this particular protocol in the study to explore early development. Why we chose food diaries over 24-hour recalls is that we knew for this particular set of caregivers that they had a special interest in diet and that they were highly motivated to write down everything that their child ate. Especially important was that not only did we have them complete the food diaries, but we also spent quite a bit of time developing quality control protocols, both for data collection and for data entry. We got about a 70% response rate, which is not bad. And most of those data were able to be used. Those that were excluded were because we couldn't get more than one day from some individuals. So food diaries can work well. Other traditional methods of dietary assessment include food frequencies and checklists. The beauty of them is that they demand less subject burden. And they can be tailored to specific questions that you want to know. Suppose you want to know more about fruits and vegetables than you do about other things. A checklist would be a good way to go. Alternative methods that are really just under development include things like food photography, having your participants take photos that eliminates their need to estimate portion sizes. That's the good news about it. However, I do need to say it is an expensive method. It requires a lot of data storage ability and a lot of staff time because it's not as simple as somebody capturing a photo and sending it to you. You do need to remind them. You do need to follow up and make sure of what you're getting in that photo and that the photo is good. And if they forget to take that photo for a particular eating occasion, you get no data whatsoever. We've used this method in our HEROES intervention that was aimed at young children. It was a technology-based intervention. So we decided to use a technology-based dietary assessment. What we were able to find from it was not only nutrient intake and dietary quality, but we were able to look at the concordance of parent and child meal timing. And additionally, you get some extra information like, wow, when you text the mom to find out what they're going to eat that day, she writes back and tells you, I have absolutely no clue. This is what you get. You get pictures of before and after for mothers and children. And what it allows you to see are things like the portion sizes that are being offered, as well as the information about foods consumed. There's also direct observation as another way that you can go about collecting some data. It's tightly controlled, so you eliminate some of the noise and messiness of other data protocols, but it takes lots of staff training and it can be quite expensive as well. The good news is that it can give you some information about dietary behavior. For example, we've used it in a setting where we were interested in looking at changing what's available on children's menus. What it allowed us to do was also to look at ordering behavior as well as intake at that meal. So for some concluding thoughts, it's really important to match the assessment to your research question. What is the goal? Is it specifically about the nutrients, or are there other things about your population of interest that you want to consider? There's no perfect method. It's what's best for the time, the money, and the participant, and quality control is key. Thank you, and I'd like to introduce the next speaker, who is Linda Van Horn from Northwestern University.
Hello. And thank you. After that excellent introduction and summary of all of the various and assorted methods, my task today is to go forward and speak a bit more about appropriate choices for research study design versus clinical examples, as those two are limited now in this age group. So we'll move forward, and due to some tech difficulties, I'm asking for assistance with advancing my slides. Next, please. So the key factors in a research setting, you've already heard in all of the limitations related to the dependency on the caregiver and all of the considerations that were just mentioned by Susan certainly apply. The only other thing that I'd like to point out is the question of the life course, and the fact that so many of the studies now are launching early in life, but can have applications considerably longer. So it's a good idea to begin with the end in mind and consider what data may actually be valuable in considering the life course. As far as the clinical aspect is concerned, there's a limited time, standardized digital, electronic health record considerations that further complicate things. And we'll talk a little bit more about that and the longitudinal aspect of that as well. Next, please. So today I'm just going to briefly cover, in terms of the research aspect, the US dietary guidelines data that were just reviewed, because of the implications regarding the paucity of data on standardized methods that currently exist. And then talk a bit about the clinical aspects related to the requirement for a rapid assessment and yet standardized, validated, and again, having a prospective capacity. Next slide, please. The U.S. Dietary Guidelines Advisory Committee, for the first time, as all of you are aware, initiated the question of beginning the guidelines at birth. And that was a valuable experience for more reasons than one, even if it was determined that there was a paucity of data in many of these age groups. Next slide, please. Again, looking at the life stage and looking overall, the questions of insufficient evidence for most of the childhood data was a aha moment for all of us in regard to moving forward. And hopefully within the membership on this call, it will spark some new directions as far as that process is concerned. Next slide, please. We're also very much aware, of course, that the vast majority of our population eats nowhere close to what the recommendations are. And in fact, the youngest and the oldest among us are closest and yet woefully shy. Next slide, please. We also have the opportunity to look at the various foods and food groups that are consumed by various ages. And of course, children have the lower scores in vegetables and produce and seafood, et cetera. And of course, we recognize the big glaring issue is that 41% of our young people are overweight or obese, which of course has its own implications. Next slide, please. We also were able to recognize that added sugars have increased, of course, and that trying to look at those data specifically is especially important. So whatever methodology is in place, we really need to have that specificity since we're very much aware of the concerns related to added sugars. Next slide, please. Also, the glaring evidence related to the reduction in total dairy intakes over the last decade or so is further of concern, of course, due to the limited intakes of calcium, magnesium, and vitamin D. So again, trying to be specific in that regard also remains a challenge. Next slide, please. So as the dietary guidelines have come forward, the main theme is make every bite count within the dietary guidelines. And next slide, please. What's meant by that, of course, is to recognize that it's never too early, nor is it too late to start eating healthy. So that this issue of making every bite count and recognizing that cumulative intake is really what is important, and yet to try to have both the eating pattern but also the nutrient specificity is important. Next slide, please. We also recognize that this issue of adiposity plays a huge role overall, especially, next slide, please. Or I think it's, yeah, if you would just go ahead with the automation, all of it. Beginning with low birth weight and childhood BMI and all of the implications that are related to the independent contributions to risk really require some combined intake data that relate to both the diet and the anthropometric and other measures. Next slide, please. The rate of weight gain in early childhood is better at predicting future coronary heart disease than any single time point. And that too relates to what I said earlier about longitudinal data needing to be collected. Next slide, please. The other thing that has become very clear is that parents' cardiovascular health is the strongest predictor of a child's cardiovascular health. These are data from the multi-dimensional assessment of preschoolers that we're currently involved with here at Northwestern. And this further is a thought that I think any of us that are doing work in toddlers and young children need to keep in mind, that ignoring the parental influence and the preferably the mother's diet during pregnancy is especially valuable. Next slide, please. This study recently just published within the last couple of months by Lindsay Poole and colleagues. It was further doing an extensive review of childhood risk factors in adult cardiovascular disease, looking at it much more detailed than previous studies have been able to do. Next slide, please. And of course, what was further illustrated is these different life course models that are yet to be fully evaluated, as far as whether the risk is actually a chain of risk or a cumulative sense of added risk factors, or whether there are critical sensitive periods that occur over the life course. But I think we are all recognizing that it is cumulative and systematic over the life course. Next slide, please. The review was actually quite detailed and useful in looking at both subclinical cardiovascular disease and clinical evidence, with, in some cases, such as increased adiposity, as you see on the left, far more data that relate to that being a causal and influencer as far as developing cardiovascular risk. And the numbers drop off dramatically. Next slide, please. When it comes to some of the lifestyle factors, if you notice that dietary quality, there were only 9 papers that qualified that attributed to these kinds of questions. So the need for collecting data, dietary assessment data, and lifestyle factor data is pressing. Next slide, please. In addition, Amanda Perrick published a paper on associations of maternal cardiovascular health and pregnancy with offspring cardiovascular disease, and also recognizing that pregnancy offers this window of opportunity that has an influence in the child. Next slide, please. But what is fascinating is that, the ability to look at these trajectories over time, considering other factors such as the epigenetics involved and what ultimately can help influence an improved trajectory over time, is something that we actually are doing currently with a study called KidFit that represents offspring of overweight and obese pregnant women from a previous study called MomFit, that puts these children at extra risk of developing obesity themselves. And as part of the American Heart Association strategically focused research network research, we're looking at whether that trajectory is improved among children of moms who had a DASH type diet intervention, and that being perpetuated during childhood. We have yet to see what those results are. Next slide, please. And KidFit, just to give you a full appreciation, involved a DASH type diet, as well as, of course, recommending physical activity and sleep and limited screen time, etc. Next slide, please. The DASH diet, the reason I'm emphasizing this is because it did offer an opportunity for both the mom and the child to look at trackers that related to the recommended DASH type diet. Next slide, please, in this age group, so that it was a simple checkoff. So from a clinical perspective, we actually had a small pilot study in a primary care setting that allowed us to do some telenutrition and had that opportunity as well. Next slide, please. So finally, just to point out that precision nutrition is, of course, of high interest right now. And so once again, the ability to collect diet data in this age group, starting at birth and continuing through the young ages longitudinally, along with some of these biomarkers that are now going to become more apparent, will certainly be of value going forward. So keeping the need for diet assessment in mind is especially critical at this time. Next slide, please. And lastly, I'll just quickly point out this paper that was just also recently published on rapid diet assessment screening tools that were available for cardiovascular disease risk reduction in various healthcare settings that was primarily focusing on adults. Next slide, please. And so providing all of the optimal factors that are of interest clinically. And of course, I don't know about you all, but every time I get asked this question, somebody says, I'd like to do a really good screening of diet in my patients, but I need to do it in under 5 minutes. And of course, we all know what that suggests and how complicated that is. But I would just bring this paper to your attention. Next slide, please. Despite the fact that it's intended for adults, I think it provides a useful example rating these various screeners from the least to the most time-sensitive questions. Next slide, please. And the opportunity to perhaps tailor and model some of these questionnaires so that they capture what a child in this age group would eat, but doing it in a quick and somewhat simplified version compared to what we would use in a research setting. Next slide, please. I think we're just going to run through these last few because it just illustrates the most time sensitive, and this one in the Mediterranean diet takes a longer period of time. Next slide, please. The paper also further points out the strengths and the limitations based on the individual's self-report versus a screener that can be completed by clinicians, which again in this age group could be an improved or a simplified way to also assess the child's diet. Next slide, please. So with that, again, the long-term goal would be, of course, to try to reduce that trajectory towards obesity and thereby enhance preserved cardiovascular and overall health throughout the life course. Thank you.
Thank you to Linda and Susan for your excellent presentations. We will have now a Q&A session with the committee members asking questions. So committee members, if you want to just speak up or.
I'm happy to start. Hi, this is Anna Maria Sigaris, and I had a question for Susan Johnson. Susan, you spoke about the use of the photography data, and I wondered if you could give us a little bit more of a concrete example of how you use that data to either change the information that came from the 24-hour recall when you did the 24-hour recall, or how did you actually really use it in coming up with a better dietary estimate for that particular child?
That's a great question. And it's exactly the kind of thing I didn't have time to go into when I was breezing through those different methods. When we used food photography, we did it in a couple of different ways. Our first choice was to pilot it with a set of families who lived in a rural area. And because we needed to be able to collect data from a distance population or distance sample, but we also wanted it to innovate a bit. And here are some of the things that we learned. We learned that in those regions, in rural regions, some of the difficulties were access to broadband, for example. Everybody assured us that they had the ability to transmit these photos to us in real time, but it didn't really work out that way. Luckily, we had given them a device to collect this information on, an iPad, and we were able to then save and download all those data. The next thing that happened in that space was we worked with Corby Martin at the Pennington for that particular study. And we are able to collect data that estimates from those photos, because of the way the protocol is used, estimates of amounts offered, and then the second photo after the child or the participant is eaten takes a look at what is left. So the estimate there then becomes what's been consumed. And that's not really different from how you would do a food diary, for example, where you would estimate what's offered, you take a look at what's left, and then the subtraction gives you what's consumed, and then that's turned into nutrient energy information about the participants' intake. We did not, in that particular study, harmonize that with another method of dietary intake. Tracy Beckelman is going to tell you about a study later on in this webinar series where exactly that happened. There was a comparison between an ASA 24 and food photography. We were just dipping our toe in the water to see, could this be a method that would help us do this with participants, and how would they respond? And the good news about that is they liked the method and they were able to at least take the pictures. It was the transmission of them that didn't work so well in that particular setting.
Thank you.
I'm going to go next with a question for Susan, or actually for both Susan and Linda, or either of them. You both talked about choosing the right method of assessment that matches, the research question as well as the budget. Now, I'm going to assume we have unlimited budget. It's never the case, but let's take that out of the equation. So for a study in 2 to 5-year-old children, where you want to understand what they eat and how they eat it, especially longitudinally, will affect their health down the road. Which method would you choose, budget aside? And then for another study where you're really interested in vitamin D, there's this hype about, vitamin D and long-term health effects. Which method would you choose? And there are many other examples. I'm just stopping at these two.
Well, maybe I can just offer what we've done. And that is we've used 24-hour recalls in our study of 3 to 5-year-olds, primarily because we are very interested in not only the adherence to a pattern, but also exactly those questions. As I mentioned in my presentation, questions related to vitamin D and the lack of dairy intake, as well as some of the other micronutrients, is important to us in this age group. And also because of our interest in maternal, fetal, pediatric relationships over the life course, having those data across the board gives us precision, or greater precision from the diet assessment point of view, but then also allows us we collected breast milk, for example, and we have yet to analyze some of the other biomarkers that we have collected. But I think the further we get in terms of precision nutrition, that will certainly be coming forward over these next several years, I think the opportunity to have data that is especially relevant, even at that level, could be of great importance and value. So that's our reason. But Susan, you may have other thoughts about that.
Well, I'll just add to that a bit. You picked a great nutrient to go with as an example, Donna, in that it comes from lots of different sources. So we can become more and more precise about how we measure the dietary sources of vitamin D, but that's not going to be adequate to give you true insight into vitamin D status. And so, as Linda mentioned, combining that with more precision methods that include metabolic status in addition to dietary intake, because what we're not accounting for is the sunlight factor or the skin pigmentation factor. And that's the challenge of trying to understand nutrient status. Mm-hmm. So there's dietary intake and there's nutrient status. And how do those things overlap, and making sure that we account for both? That's what I think is the important thing to do, irrespective of what method you choose to measure dietary intake.
Thanks. I think we have time for one more question.
Oh, great. This is Erica Gunderson. Lovely presentations. Just so happy that you included the life course and life stage, and you looked at these various methods in detail. And I guess my question has to do with diet quality in terms of longitudinal prediction of future disease and disease of cardiovascular health, and then cardiovascular disease longer term, which is very long-term study. But talking, giving a sense of the methods or the target components of the diet that you would think that are very important in these different life stages. And also just ask you to consider breastfeeding lactation as a benefit to women's health long-term. But that's an aside.
Linda, I'll give you a shot at that first and add to it.
All right. Well, thanks, Erica, for that great question. And of course, that's uppermost in our minds also. And also recognizing that, the only study that we really have that has gone from pretty much birth till I think the population is now 20 years old is the STRIP study, and that study has been sort of the groundbreaker as far as trying to look at some of these questions. And it was, of course, based on food records and interviewer assisted diet data collection that is now, 20 years later, coming into play. I think the other thing that we're recognizing more and more is diet quality is absolutely valued in regard to the microbiome and everything that transpires from that, including the risk for developing obesity. And again, in the study that I was mentioning, the KidFit study, where we know these children are already at high risk of developing obesity, the idea of both questioning lactation and how long and the quality of the mom's breast diet during lactation, as well as even prenatally. We don't know yet exactly, which nutrients are affected. We think certain fatty acids are, but, to be able to quantify that and actually put data behind it really has yet to be fully documented. So I think, again, it's just a question of beginning with the end in mind and opening the door for data collection that can be valuable in systematic meta-analyses even in the future.
So I'll add just a brief bit to that. And this is maybe my bailiwick. But as I understand that cardiovascular outcomes are hugely important for us to understand long-term, there are other aspects to understanding dietary intake in children that are also really important, and that's cognitive development and cognitive decline on the late end of the life course spectrum, as well as motor development and all sorts of pieces of development that rank right up there with cardiovascular disease. And so I think from the dietary assessment perspective, we have to keep all those things in mind about how we're going after understanding diet quality, diet patterns, and the building of those over a lifetime.
I could I just want to add, in terms of the Dietary Guidelines Advisory Committee reviews, neurocognitive development and seafood intake was the only area that actually had a modicum of data related to that relationship in a favorable direction. So totally agree with that, Susan, very much.
Well, thank you. That takes us right to our time for a 5-minute break. Stretch your legs, grab some coffee, and be back in 5 minutes. Welcome back from the break. We are going to move forward with our next speaker, Dr. Andrea Anatar from the Research Triangle Institute, who will share lessons learned from the Feeding Infants and Toddlers study. Welcome, Andrea.
Thanks, Lisa. Okay, so I want to begin by thanking the National Academies and the Planning Committee for assembling this important workshop and inviting me to present. So for my presentation, I will discuss our approach for assessing intake of food and dietary supplements for toddlers in the 2016 National Feeding Infants and Toddlers study. So as we've already discussed this morning, this accurate assessment of dietary intake is critical in our efforts to understand influences on eating patterns and assess relationships between diet and health outcomes, particularly in young children, because as we heard, those early practices affect health across the life course. The Feeding Infants and Toddlers study's cross-sectional dietary study focused on infant toddlers and preschoolers living in the 50 states and DC. It's been administered 3 times, 2002, 2008, and 2016, and over those years surveyed nearly 10,000 caregivers to gain a better understanding of the food and nutrient intakes and related lifestyle behaviors among young children. The primary objective across all 3 time periods has been to assess food and nutrient intake of these youngest children. So while the age of the children has broadened across the years, more emphasis has been placed on modifiable risk factors for disease, particularly obesity, and looking at special interest subgroups like WIC. The overall objective has remained that's the same. So specifically in 2016, our key outcomes of interest were usual intake, food, beverage, and supplement sources of energy and nutrients, the food consumption patterns of these young children, their meal and snack patterns, contributions from the major and minor food groups, and comparison of energy intake to estimated energy requirements. And then in 2016, we also wanted to look at patterns of intake across the 3 study periods. So how did we do this? 2016 was designed to be consistent with FIT's 2002 and 2008 to permit these comparisons. But also, we wanted to be permitted to make modifications and question choices to reflect scientific literature and influences on lifestyle and diet and eating habits of infants and young children. Considering our outcome of interest required dietary specificity and the size of this being a large national study, the ease of use, lower respondent burden, and cost effectiveness. For all studies, we've used 24-hour dietary recalls with proxy reporters. We've heard already, and will be more over the upcoming days, that novel technologies are being increasingly integrated or other approaches to help improve the reporting of the 24-hour recalls. And Nick's even going to speak a little bit to this right after me. So prior to beginning data collection for FITS 2016, we added several hundred infant and toddler food products to the FITS 2016 food database to reflect consumption habits and products available in 2016. And to make sure our food and nutrient database included foods consumed by this youngest age group. More about this will come. We randomly sampled English and Spanish speaking parents, guardians, or caregivers of children 0 to 48 months of age who were selected randomly at the time of recruitment for either the 1 or 2 dietary interviews. We intentionally sampled 12 separate age group sample size targets within this age period of 0 to 48 months to align with key developmental stages during this critical growth period. And we also had specific WIC participation target goals within each of those age groups so that it would permit comparisons. So after the respondents were recruited by phone or online and completed an initial interview, they were mailed a package containing materials to assist with this 24-hour dietary recall. Respondents then completed a phone interview by dietary interviewers, certified dietary interviewers at the University of Minnesota's Nutrition Coordinating Center using NDSR, during which they were asked additional questions about the child's eating behavior. And as a proxy for the child, they completed a 24-hour dietary recall. So it's already been mentioned, parents are typically relied on as proxy reporters for capturing dietary intake because young children typically thought of as, those less than potentially 8 years have immature cognitive abilities, have a hard time estimating portion sizes, have incomplete concepts of time, and obviously potentially limited knowledge of food names and preparation methods. So our protocol was similar to what's used in NHANES with proxy reporting for children under age 5. Interviewers were provided with a list of toddler food products on the market during FITS 2016, but not included in the NDSR for reference during the recall. And this list was used to help probe the respondent for specific brands or details about these toddler-specific foods. 25% of the sample completed a second diet recall at least 7 days later to reduce our measurement error and eliminate within-person variation, allow us to estimate usual nutrient intake. Our respondents were more likely to be white, less likely to be Hispanic, and more highly educated than the US population, with adults in households with children under 4 years of age. The sample was calibrated and weighted to help reduce this potential selection bias and other sources of bias. Okay, so to improve the accuracy of the dietary data reported and to evaluate specific questions of interest, which were trends in toddler foods, what are they doing now? So much had come on the market just between 2008 and 16. We made several enhancements to reporting. So in addition to the standard multiple pass method employed in NDSR, additional probing was done throughout the interview to remind parents to report not only the foods consumed, not any portions, to report only the portion consumed, not any portion spilled, left over, or otherwise not consumed by the child. Overestimation is a common issue with proxy parental person. And as Linda mentioned, every bite counts. We've seen in this new, the new dietary guidelines, particularly with the small amounts consumed by these children. We included probes and tracked organic foods, food consumed from pouches. Not only baby foods are consumed from pouches, but also these toddler foods, applesauce and yogurt. And we tracked 100% fruit juices diluted with water. We made enhancements to the food model booklet to reflect current products and serving utensils for this age group, and I'll talk a little bit more about this in a second. And we included a specific list of most commonly consumed and frequently forgotten foods from our experience with previous FIT studies and other young children studies, to serve as probes for multiple passes used during diet recall. So prior to the dietary recall interview, after the individuals were recruited and completed that initial interview, they were mailed a box of materials, which included materials to assist with reporting accuracy, a visual aid booklet, and a foods fed by other adults form. All of these were in both English and Spanish. I'll talk more about those in a second. But other items included in this package, and you can see a picture of the package on the left there, were a 12-inch paper ruler to assist respondents in estimating the thickness of foods like a brownie, and a plastic measuring cup with instructions on how to measure the volume of the child's most frequently used cup. That's this picture on the right. The measuring cup was intended to help us alleviate the challenges in determining how much volume was held in the wide variety of children's cups on the market. So specific instructions were given of how to measure this volume to increase consistency and reduce that human error when measuring volumes across the household. So they were told to do that in advance if they could. And then, as would be expected for a regular recall where you have a measurement booklet or aids, We included life-size drawings of eating utensils, drinking vessels, plates, bowls, in various shapes, images of mounds and on a plate, circles, triangles, wedges, squares, rectangles, all the different kinds of shapes and sizes foods come in. And then for these younger children, we improved on certain things specifically. There's a food grid I'm not showing here, but we made the markings at smaller intervals to get more refinement and specificity in our measurement. We updated the sippy cup drawings to actual sizes to include a commonly sold cup. We looked at market research to see which were the most popular. And we added drawings of various pouch sizes using actual sizes. And then we used actual size drawings of infant and toddler feeding spoons and draws of commonly used toddler bowls. And as noted already on the first page of the booklet, we included a list of frequently forgotten foods in addition to a list of meal and eating occasions so that the respondents could reference them. So this has been talked about already this morning. Obtaining accurate data on the intake of toddlers is commonly complicated by the fact that persons other than the parent are responsible for feeding. So Lisa noted many children of this age spend a large amount of their time within childcare settings or the home of another or with a nanny. So commonly, kids in childcare centers at least may have some familiarity with what is served in the setting. They may get reports from the school of what their child consumed in the exact amounts. If this was the case, we collected that information as part of the recall. But if it was not possible and the child was in the care of somebody else during the day of intake and the respondent did not feel comfortable reporting, the caregivers were asked to obtain as much detail as possible from other persons who fed the child on the day of the assessment, using that form, foods fed by other adults form. And you can see a picture of it here. And that was mailed in the box, but they could also get it from the interviewer at a later time. Interviewers then called the parents back at a prearranged time to collect the information or collected the respondent's email address to send them instructions for emailing the information to them. If a parent could not be reached to provide the usual intake amounts, the QA scientists used the USDA child care meal pattern, and in the case of our littlest ones, the infant meal pattern guidelines for reimbursable meals to complete the record. In a few cases, rarely, because this is a lot of burden on the interviewers, an interviewer called the other caregivers to complete the child's recall. We gave them 10 attempts without daycare before we expired that case. So 10 accounts via phone or email to try to get this information. Okay. So our database, talked a little bit about this already, but NDSR is constantly updated with foods and nutrient values to reflect current market and updated with releases from USDA. Even so, the food and beverage market, particularly for these young children's food, is constantly changing. It really was in 2016. So all specific food and beverages and brands are not in NDSR. So in advance of data collection, as I told you, the database was enhanced to reflect consumption habits and products available in 2016. We added several hundred specific young child food products. And then further, interviewers had to confirm if foods were child or adult because it made for different classifications and matching within the database. And additionally, because the focus of this study was on young children's eating behaviors during the data collection phase, user recipes were required to be created for all baby and toddler specific products not in NDSR. So that was an ongoing enhancement. And then those would be available for subsequent data collection. So to do this, University of Minnesota performed calculations to adjust the amounts of the major ingredients such that the nutrient values of the ingredients best match the nutrient information: calories, protein, carbohydrates, sodium, fortification nutrients of the new food, and made sure that they fell within the NCC's established nutrient tolerance levels. If information was not available, missing foods were resolved using manufacturer information or user recipes created from previously resolved missing foods. If the food still could not be resolved, their best professional judgment based on available information was used to produce a recipe. All foods and beverages reported in the recalls were assigned to food groups through the use of a food group classification scheme aligned with the USDA's What We Eat in America, and to the extent possible, the FITS 2002 and 8 food classification systems. Okay, we also collected reported supplement intake over the past 24 hours for multivitamins, vitamins and minerals, prescription vitamins or minerals, fiber supplement, over-the-counter antacids. If we could not get the respondent to produce the container of the value, the ideal, which we talked about in the last seminar, we would default to a closely matched generic product. If the product was not available in the DSAM, the dietary supplements database, it was entered in as missing, and the respondent asked for as much detail as possible: the name, the ingredient, serving size, quantity, serving size unit, frequency it was taken. And then we followed a similar process for creating a missing food for that supplement. Okay. So extensive review processes barely touches on it, but recalls were reviewed for missing foods, unrealistic quantities, and supplement use. Importantly, they were considered complete if no more than one unknown snack eating occasion was reported, and basic information was provided for a meal or food, such as the food category, to allow NCC to impute the most frequently reported food in the reported food category. So if it was cereal, we would impute oat bran cereal, and the portion size based on the age of the child. Okay, take-home messages. Flexibility in enhancing the food database, essential for the study's success. That is the real advantage of us using NDSR, is that we didn't have to wait for a lag time. We could do it in real time, and we could preload it in advance with relevant foods for this population. Robust, flexible, updated tools to enhance portion size. Reporting portion size is the part that, with this youngest age group, the studies have shown have the biggest challenges. So we had these updated tools, but we also had these strategies with these additional probes built in to constantly remind people only report what the child ate, not what's on the floor, not what's left on the tray, not what's just sampled or tasted. And then the systematic method for maximizing the quality of information obtained from multiple caregivers, since they aren't always with that single one, having a very organized way of doing it. But it is immensely challenging, as we can attest to. And then multiple levels of quality control, checking in on it throughout the entire process, and providing constant cycle of feedback. Okay. So with that, I do want to acknowledge Nutrition Coordinating Center, Lisa Harnick is with us today, and Julia Lorenza Peasley, who helped us so much. My colleagues at RTI and the scientists at Nestle Research. And now I'll turn the conversation over to Nicholas Horton of Amherst College. Thank you.
Well, thanks for that opportunity to really hear about the lots of questions that I think are quite highly relevant. We've structured these 4 talks to really be able to build on the kind of questions that are here. And my job today was to really be thinking about how we could be analyzing data from these multiple informant reports. I've posted my slides available on the link in the chat. And again, my job here is really to be thinking about how we can be dealing with some of these discordance reports. And I think about multiple informants very broadly. It includes both the proxy reporters that we've heard a little bit about, and also alternate measurements, maybe with just one reporter. This is relevant for what we talked about about pregnancy in the workshop last week, as also for older kids, but I think it's particularly salient when we're looking at integrating this information when we have very young kids. And so, as I said, I've given the link there. I'll come back to it in just a minute. We also want to kind of briefly acknowledge a number of collaborators and others whose work I'm going to mention today. There's a link to kind of a website that discusses methods for multiple informants. But I want to jump straight into how and why this may be relevant in this setting. And the work that I've typically been doing has been in the use of multiple informant reports in the studies of children, but more in child psychopathology. The reason that these are often used for children is that they are not reliable reporters. Certainly when we think about food and supplement intake for very young kids, that's certainly very true. And really an inherent feature about it is this idea that we would expect discordance from it. There's considerable measurement error. And when we think about the last 3 talks, we've heard lots of different ways that measurement error really compounds. It's really critical if we're going to be going ahead and trying to understand levels of nutrition, supplement use, dietary intake for kids and women during pregnancy. It's really going to be important to bring these multiple streams of information together. If there's no discordance, there's no need to collect this, what would otherwise be redundant information. We heard a little bit in the first workshop about ways you might not need to repeat certain things, but I think there's lots of places where we could be eking out additional information that will be valuable for us. So 2 sources of discordance. One would be this kind of random measurement error. Another one I think is important to be thinking about and distinguishing is that each informant or each source that we'd be thinking about is tapping into different aspects of the underlying construct. They may not be commensurate in some ways. And this idea that there could be this different measures means we have to be careful if we just combine them in an ad hoc fashion. Another really important overall issue here is that missing data is going to be common or really expected, since the measures are being taken on others beyond those being directly studied. There's going to be 2 reasons for missing this. It could be missing by design. We choose not to collect measures of some subjects or some informants, but it could also be by happenstance. Someone was too busy to take the pictures of the food that day in the food photography example. I think of these questions, multiple, missing data and also multiple informants, as being job security for statisticians. We know that the budgets for surveys are going to get decrease over time. We know that missing data is going to become more common. We've seen that kind of trend, but we need to be able to kind of extract this information in more sophisticated ways. So again, today I'm hoping to briefly provide some useful analogies from some of the work that I've done in other areas for nutrition and supplement assessment. So one kind of quick question, why not just pool reports? This is probably the most common approach that people might do. But the problem here is that the optimal algorithm for combining reports depends on the type of measurement error that's present. We don't typically know that. As well, the pooling can result in loss of information about source-specific effects. If what's being reported by the child care provider is different from the mom in important ways, that may kind of lead to other issues and problems, and we might want to be able to try to correct for what those different informants are reporting. The pooling also doesn't permit the examination of differences and risk factor effects across sources, and probably most importantly, the pooling algorithms are not clearly defined in the presence of missing data. And so kind of the idea of pooling is kind of a simplistic but probably not recommended approach. Another common approach is to think about separate analyses when you have multiple informants. The problem here, of course, whenever you do separate analyses, you can often get different multiple sets of results for the different sources, and you kind of have to choose which one to be thinking about. That there's no way through such separate analyses to formally evaluate how similar or the different the results are, or to go ahead and consolidate them or summarize them in a single set of results. And then the problem again of missing data, that the separate analyses may be based on different subsets of the data. And if some of the subjects are missing one source, others are missing another in some systematic way, that could lead to some issues and problems in really understanding and creating the right inferences. So in summary, neither pooling strategies nor separate analyses, I think, address the potential bias resulting from missing data in this setting. So some prior work described a flexible model, a regression approach that incorporates all multiple source reports in a single multivariate regression analysis. This method is attractive because it can test for source differences in the outcome and the estimation of different source effects when necessary. When we know that there are some systematic differences, we can incorporate and allow the model to include that. They can also test if the effects of other risk factors on the outcome differ by source, Perhaps there's a differential difference between the informants for, for boys versus girls, or for some other important factor. And probably most importantly, the model can include partially observed data from subjects with missing source observations and reweight both in the ways that you're looking at national estimates through the FIT study. We can also be thinking about the design weights there and also missingness weights as a way of accounting for systematic dropout. We can also be thinking about the use of multiple informants as predictors. And there's some work, also that described another model that allows these multiple source reports to be predictors of some other outcome. For example, we want to understand nutrition levels and how it relates to being overweight or obese. This model can also be used to test for source differences in associations with outcome and incorporate the same kind of different source effects where necessary. So I wanted to give a little bit of some examples of different areas and how these have played out. And the first one, most common one, I think, is that of child psychopathology. So here's a table from Achenbach's paper from 1987, where they were looking at the correlations or concordances between informants of understanding a measure of child psychopathology, internalizing behaviors, externalizing behaviors, or something similar. And they had these six different informants. And then along the diagonal, we see kind of correlations between informants of the same type. So parent to parent, or to teachers, to mental health workers, to peers, or kind of self-report, kind of test-retest reliability. And those tended to be fairly large, certainly for psychiatry diagnoses, correlations about 5.5, 0.6. The off diagonals, for example, between parent and teacher, tend to be lower, here around 0.27. But the idea that you could be thinking about these different measures and different kind of informants. Now, obviously, there's a lot of time and cost collecting this information. Few studies collected all of these different informants, but it gives, I think, some ideas of how you might be expecting, just by construction, how different informants might be giving you relatively low correlation in some of these measures. But that also implies, I think, there's additional information there that could be brought out through some additional analysis. A different application was thinking about linkage to primary care. This was in a substance abuse study. And the way things were structured here was it was combining a self-report measure. Sometimes that was missing because people were, lost to follow-up, and also administrative report of some linkage, so electronic health records. And I think analogous approaches could be useful thinking about some aspect of chart review or other information. But we can think about the same kind of approach here of kind of two measures of the same thing, but just coming in through different structures. And I think we also found in this example, lots of places where one was missing in some cases, one the other, but we could get a better synthesis by pulling them together. Other colleagues and other researchers have looked at approaches to think about dealing with multiple measures of depression. In the kind of analogy I'm making here, this might be kind of the difference between a food frequency questionnaire, 24-hour recall, or other kinds of approaches where we have different kind of measures, but they're all tapping into the same underlying quantity. So Junaid Sadiq et al. Kind of thought about harmonizing longitudinal non-commensurate measures. So here they had the kind of children's depression rating scale and the Hamilton depression rating scale and others. But they wanted to kind of bring together for studies that measured one but not the other, how they could be kind of working between the two and harmonize them. Similarly, I did some work with Jane Murphy and colleagues with the Sterling County study, where we kind of tried to map from an older to a newer version of the depression measure, the DPAX-1 and DPAX-2 that they've been using. And again, these kind of approaches to allow you to bring these non-commensurate things together in one underlying framework. A paper that I also worked on thought about approaching this as a latent variable problem. We might have one or more latent traits that are associated with certain indicators that are observed by different informants. And it kind of laid out a hierarchy of these dependents or correlated latent variable models. But the idea of this is that we can kind of really be reducing the measurement error by bringing together the information using these more principled models here. And these were used as multiple informed reports of exposure to violence that was then used to predict a respiratory outcome in these kids, where we had both child and parent report of such exposure. Kind of one that's kind of a little further afield is that of identifying triggers for HIV testing. And here the idea is we might think about a lot of different indicators of measures that are kind of somewhat distally related from our overall kind of sense. So if we had kind of some measure of good nutrition, but we had different indicators. This was done in an HIV study where we were trying to understand what was triggering HIV testing. And so for each of these, there were a whole bunch of other aspects in the chart that could come out as dichotomous indicators of, for example, weight loss or community-acquired pneumonia, and to try to estimate and try to understand the different relationships between those triggers. And this, I think, can give a better sense of which triggers were important, which could be kind of talked about through physician education. I think the same kind of approaches, thinking about kind of different indicators that are measured through some of the studies we've heard earlier, I think could be very valuable in kind of bringing that together. So I want to kind of, come back to assessment of nutrition and supplements. I think there's lots of work here, lots of opportunities. It's been remarkable so far to see the work that's been going on in these areas to creatively and efficiently try to pull together this information. I think there's additional potential for us moving forward to be accounting for missing data in other ways. The idea of a rescue question for those lost to follow-up that could be used to kind of tie in with more comprehensive measures, to think about ways of combining some of the parallel measures that we've been hearing about, to incorporate aspects of food photography where information may be available only on a subset, by design or by happenstance, that we can think about incorporating direct observation, perhaps on a very small subset, and extrapolating that to others. We've seen creative approaches where matrix sampling can be done, again, by design to minimize respondent burdens. And I think overall, there are lots of ways to think very creatively about data fusion for non-commensurate measures. I start to think about how we kind of combine the nutrition and food versus supplements. The end game is going to be both of those pulled together. How can we kind of be thinking about disentangling those? Again, comparisons of 24-hour recall versus food diaries, ways of kind of thinking about respondent bias, systematic sampling, really incorporating other found data that might be available that kind of goes with the really well-structured systematic data. And then thinking about other aspects of metabolomics and others that may be very different. I think there's lots of lessons. We briefly mentioned MEMSCAPs last Friday, these medication event monitoring systems. A lot of time and attention put into those, not that much information at times. So how can we really be getting the most bang for our buck as we go? There's lots of open questions here, and I'm looking forward to the remaining conversation and the remaining webinars. Really coming back to Susan's questions of what's the question of interest? How do we think about, what needs to be measured? This is clearly an understudied area where I think there's important public health applications, and we really don't understand really many aspects of it. The FIT study, I think, talked about what quantities we're trying to measure, and I think we can be thinking more about those. And then really kind of this trade-offs. How well do we want to measure? How much effort and resources are we willing to expend to get there? So in just take-home message, I think that by collecting this information, analyzing it, it can help to augment our primary assessment and deepen our understanding of nutrition and supplement use. Again, I'm looking forward to the conversation and really appreciate everything. I've included the slides and some references, and I'll leave that for now.
Thank you so much, Nick, for that really informative information that you gave us. And, having collected dietary information on this age group for quite some time and realizing the fact that our customary approach is just to blend all the information together to get a comprehensive 24-hour recall, you've given us some really interesting food for thought, pardon the pun, because as Sue Johnson and I were thinking along the same lines, sometimes kids eat differently for different types of caregivers. And if you don't actually take into account who the informant is, you might be missing that important detail, especially when you're thinking of intervention studies. So thank you for that thought and the presentation. I see some hands up and I'm going to call on them as they show up on my screen. So Amy, do you want to ask your question?
Sure. Thank you both so much for really informative presentations. I enjoyed listening to you. And I have a question for Nick about the methods for multiple informants. And in particular, how do they accommodate a lack of knowledge about overlap of the reports of the informants? So, for example, in depression, I think maybe we're evaluating the same underlying construct, but in some cases, a parent might not even remember or know where a food item was consumed, carpool on the way home or something like that. So are there ways to accommodate that in the methods as they are right now?
So I think we heard about that as well, Amy, last week when we kind of, if a big drink wasn't thought of as food, we're going to be missing that. And, all the efforts that go into kind of, helping the informants understand what's really being measured are really important. But being able to then kind of assess whether or not, we're missing certain things based on, some other aspects. So I think this idea of kind of incorporating and seeing differences in what's getting reported in different parts, and then combining them, as Anna Maria has said, combining them makes sense if they're commensurate. We want to be able to do that in a principled way, though, and look to see if if certain age groups are coming in differentially. There's other aspects that there are these kind of differences, and I think that as we start to kind of pin down really what's most important to us, and again, this may depend on the particular analysis or the particular study, trying to kind of be able to pin down a little bit better, you don't really need to worry about that so much because it's pretty well measured and consistent. But for this, we're seeing these differences. And I think those can have implications both for design and analysis.
Thanks.
Thank you. Stephen Daniels.
Thanks. I guess this is a question for both Andrea and Nick. For older children and certainly for adults, I think we know about issues related to underreporting and sort of issues of bias that might be related to social desirability or what the reporter thinks we're looking for rather than what's actually happening. It strikes me that when you have multiple informants, you might have different levels of that influence on reports of intake. Parents might view this differently than daycare workers or other kinds of things. So I'm wondering what we know about that, how much we know about that, and then how we might handle it in terms of data analysis and interpretation.
I don't know admittingly, I don't know a lot about this. From what I have studied and what I have learned, where they have sought to try to find out how the estimates compare between what the parent reports in terms of intake versus the alternative feeder. Commonly or interestingly, the parent will tend to underestimate those portions consumed at home while estimating those consumed within the daycare setting. So I'm not entirely, sure how we handle that. Nick, probably maybe you have a proposal for how you work with those estimates to try to, I don't know, or correct them if there's anything that we can do in terms of the analysis side. But they have done, I have seen some studies done actually using even the FITS data where they looked at the parental report and then did weighted studies in the daycare setting to see how they aligned. And again, they commonly saw the discrepancy between the over-reporting and the under in terms of some.
I think this is a really interesting area because, there's lots of examples where things have been somewhat counterintuitive. For example, in the Black Women's Health Study, they found that the respondents were were more reliably estimating their weight compared to objective measure than their height. And that was probably due to more rounding error. It turns out there was a systematic bias of underreporting weight, but nonetheless, particularly when you were looking at differences over time, those were pretty consistent, that some of that bias dropped out. And I think that's kind of encouraging in terms of some of these measures. For other ones, if we are seeing that difference, and it's different by certain groups, or if people are consistently doing it, I think it will allow us to be thinking about a kind of a model that kind of brings that together in some ways. And so here, Andrea, I'm also thinking about some of the work, that we heard about earlier and others, where there's some direct observation, there's some, photography, where we can start to kind of triangulate on better measures, even if some of them, are going to be not cost effective to be doing throughout. And I think that might give us more of a sense of where they fall down, where they, work pretty effectively.
Nick, could you do that on like a part of them or a small group of them, and then it expanded to the larger?
Yeah, again, that aspect of, creating a missing by design, if it's missing by design, I feel so much better about who's measured and who's not. And so kind of thinking about the kind of a classic epidemiological validation study of how I might think about optimizing who's in that little validation study, but this provides a measure to kind of bring that forward so that, again, in a large, well-characterized study, you could be thinking about some smaller sub-studies that could let us try to get, angle. Now, those are going to be underpowered for looking at kind of, different education levels or other kinds of subgroups, but they could, I think, give us an overall sense of, here's, what we get close to a gold standard. Now, there's no gold standard in psychiatry. There's certainly no gold standard here, but I think trying to get that better sense of, if we're willing to spend a lot of time and energy to kind of figure out what people are doing. And by that, I'm thinking the food photography, some of the direct observation, and some of the other approaches. Again, can that be extrapolated to the larger group?
Thank you for that. Cheryl, you have a question.
Yes, thank you, Anna Maria. And Nick and Andrea, what a wonderful set of presentations. I really appreciated hearing your talks. I have a question about supplements. So, Andrea, you mentioned very quickly in FITS.
I know. Sorry.
Yeah.
Sorry, I was like, oh, sorry.
It's a chance for me to just ask a little more. In FITS, they were bringing in their pill bottles. Hopefully, if not, you were sort of making best guesses in terms of what might match up. I'm really wanting to take a little deeper dive on, for the more commonly used supplements, how well integrated are those into some of our tools? Are you finding that people might need to be creating separate supplements? And then maybe Nick can talk a little bit about, on the back end, how do we handle that from a statistical perspective?
Yeah, so we followed, obviously these are studies that are done multiple times, and we are very interested in the trends data. So we followed the procedures that had been used in 2008, Cheryl, which did not exactly use the DSAM, but used extrapolated for specific questions, those questions that I just threw up on the screen really fast. And ideally, they would have the package with them. On the back end, admittingly, there was some work that we had to do that wasn't accounted for those most common types of supplements that we know the children consume, the drops, especially the infants, the gummies, and the chewables. I should know this, I've got 3 little ones. To account for the classification that would then take into also account, we know, in terms of the bioavailability and all that. But does that answer your question of how the type of information or how much it's incorporated? So it was built in as formally at the very end of the diet recall, the formal supplement module was included, but somewhat modified to conform so that we could make comparisons. And then we did perform the analysis both with and without supplements, so that we could see the amount coming from food versus the values with the total intake.
Cheryl, I think that's a great question because it's doubly complicated, right? You know, everything I've been talking about with multiple informants could just be on food intake or just on supplements. And this question of how to be combining the kind of food information, the supplement information, I think is still, you know, lots of room for opportunity where we can start to think about those maybe as two latent variables, to kind of use one of the models and analogies, that are then used to kind of relate to some important outcome, for example, overweight, obesity, or some other kind of, you know, disorder or other kind of approach. And I do think there are ways of doing that. And it's going to be incumbent upon us to be collecting that information in various granularities to let people kind of who are focused maybe on you know, vitamin B12 or something specific to be able to disentangle that from some other approaches. But it's to me really important to try to get a handle on that and, you know, figure out ways where some of the metabolomics might help us in guiding kind of, you know, some level of connection for that in terms of kind of what's going on within the individual.
And can I add one more thing? Sorry, I don't have time. So just on the analysis side, and Diane Cotillier will probably be able to talk more about this on if she's asked on. She's our analyst on this on the fourth webinar. But one of the issues that we had that I know Kevin Dodd at NCI and Reagan Bailey helped us with some was that the current macro doesn't really account for the supplements. So we had to, you know, create distributions by age and then randomly sample from the distribution and impute the values. So if you have differing values of the supplements that you take on the different recalls, it, you know, we do then have a problem in our estimations, which is something that we bring to you, Nick, to try to figure out how to resolve. So they don't integrate terribly well right now. It's a limitation.
Thank you. So Donna, did you have a quick question to ask? We're now going to move into the session where we can ask questions of the four panelists, and we also have some questions that were sent in from the attendees that I'll be able to ask. Do you want to move on?
Yeah.
Okay. So one of the questions that I know that came in was related to the fact of, and Andrea, you addressed this to a little bit of a degree, all the different foods that are specific this particular age group that that you had to actually put into NDSR in order to launch the FITS study. Are those foods then available to all NDSR users?
Okay. Lisa might chime in here, but typically no. They go, they even, oh, Lisa, I hate to put you on the spot. I think they're purged after the given study. So they're available throughout our study. And the beauty of using NDSR that we talked about last time is that in terms of if you have a file, a backup file, you can then run subsequent or previous year's data through so that you have the same most updated and consistent nutrient and food group values applied across the years. But no, my understanding is they are not, and even previous ones that we have added are purged again.
I would just say, yeah, so for individual studies, people create user recipes and they're available just for their studies, unless, you know, some people choose to share them with other researchers. For FITS, I think we did anticipate, we updated some certain food product categories knowing that, oh, this big study's coming with this age group. But for the ones we had to add for the study, you know, during the study aren't available to everybody.
Thank you. One of the questions that did come in from the attendees prior to is related to food frequency questionnaires, and not many of you discussed food frequency questionnaires, but can you perhaps provide some resources for validated food frequency questionnaires in this particular age group? Anybody?
That's I'll speak up and confess to not having a good answer to that. There are food frequencies and screeners that are available for this age group. However, it's the validation part of this that makes this a bit on the tricky end, is they're not always validated for preschoolers, and you kind of end up doing the best you can with the data that you have. That's my experience.
Okay. Another question, and this can go to any of the, I think it's more of the assessment piece, is for those of you who've collected dietary information in this age group and have used the different tools or booklets for estimating portion sizes, can you speak to the extent of which parents actually have that tool in front of them when you're conducting the 24-hour recall? And have you looked to see if it really makes a difference?
Okay, so I'll take that. I could pull up the exact statistic to you because we did record, but we obviously, if we get we randomly call people. So what we did to try to ensure that they had it in front of them was, after we recruited a person, used overnight or 2-day mail to get them their, like, a box of goods so that they were unlikely to misplace it that rapidly, and then gave them an assignment, and then tried to call them within 2 days of that. The majority of respondents did have, but I can't give you the exact number off the top of my head, the booklet with them. However, our interviewers were also trained in methods to use in case, say, they weren't at home and didn't have it in front of them, because it's so hard to get these individuals back on the phone, and you don't want to lose somebody that is, halfway through your study. And so what they can do is typically reference common objects that they would have, either if they had lost the booklet or thrown it away, in their kitchen, a tablespoon or this or that, and they can work with them through those reference of other items. But I don't have the, and I believe we looked into in advance how much difference there was in the accuracy of reporting. And so long as these trained interviewers use common objects and all that, it didn't make that much of that huge much of a difference not to have that physical booklet.
I wonder if I might add just one comment to that, in that typically gets done for that primary proxy reporter, and it doesn't always trickle down to those alternative reporters. And I think we leave them out a bit. Yes, they can contribute, but the degree to which they can contribute well depends on a number of different things. Do they get the trainings in how to do this? And to remember that in the case of childcare, they may be taking care of 5 to 20 other children. And to what extent are they really being able to focus with the demands on their staff positions on that one child? And are they paid to participate? Those are things that we have to consider in our designs.
It's a great comment.
I'm sorry.
This is Linda Van Horn. I just want to also mention that in some of our studies where we have a wide array of socioeconomic status, we were not surprised when we started trying to figure out why some of the kids were not, changing weight, improving the trajectory, let's put it that way, and discovered that frequently some of those children were being handed over to different members of the extended family, often involving a snack or a whole meal, that the child then came home and had another meal, because at that age, they're not going to know the difference between, dinner and snack and everything else. So I think a lot of this has to do with multiple caregivers and often the absence of any awareness of whether there was food involved or not during that time.
Thank you, Linda. I wanted to probe Susan a little bit more because you talked about telenutrition. And given that we've all gone through COVID and the use of Zoom as we're using right now, What do you all think about the theoretical, perhaps, opportunity to be able to use Zoom with the parent in the home to conduct 24-hour recalls?
Well, I think that that's a question that's on a lot of researchers' minds and clinicians' minds as well. They're using telehealth to go in and do follow-up with children that come to them for eating and nutrition-related concerns. I also think that there may be great opportunities to be able to merge the 24-hour recall with some additional visual information that you could gain because you're on Zoom. And it may go towards some of those ideas that Nick was talking about how do you take a small sample and combine the two methods together to really try to figure out if you can determine some of the differences in the information that you're receiving that are either systematic or non-systematic.
Yeah, I'll jump in here as well. I think that's a great opportunity to be doing exactly that kind of, information synthesis. And if it turns out that that is a more logistically practical thing, that you get more of the attention of the parents maybe, or, it's possible to do that back and forth and get some sense of what the containers are. This may kind of complement some other interviewer type approaches. And, we can start to assess whether or not it has a better connection with the outcomes we really want to be thinking about. And that may give us some approaches that allow this to kind of really be the focus during that time. But again, it will require, substantial resources to do what might feel like it's redundant, but if it's giving us different information or improved information, it might be worthwhile.
Just wanted to add to this discussion the fact that if we are contemplating going that direction, internet availability and ways to make it available to the types of populations that we work with will be essential. I'm not saying it can't be done, but particular attention to those kinds of logistical things that might be important.
And one just tiny thing to add to that. Some of our work that we've done, we found that parents tend to more accurately report, surprisingly, probably because of the you're removed via phone versus in person because of that, perception of judgment, even if you're trying to minimize it as much as possible. So it'd be interesting to study it and see how it affects the accuracy.
Andrea, that brings up the question of social desirability, and will that enter in because you can actually see the participant? And I can tell you from the food photography data that we've collected, we haven't encountered big problems with that because of the things that we've been able to see in our photos. We don't think that people are really worrying too much about the fact that we can see what they're doing instead of just being told over the phone.
Can I ask those of you who have been assessing diet once again, and it could be including our workshop participants, to talk a little bit more about assessing dietary supplements in this particular age group. And if you could sort of reflect on what you really think is the best methodology. Is it collecting it, as part of the 24-hour recall? Is it a specific separate questionnaire? To what degree have you used methodologies that have been used in adults where you ask the mom to come prepared with the supplements? Just wondered if we could have a little bit more discussion on that.
Well, this is Linda. I can definitely say that it's a valuable aspect of diet assessment, including, the intake of the supplements along with the diet, and then being able to look at diet with and without the supplements. We're currently looking at some relationships between the minerals and blood pressure. And as we all know, there's an under intake of calcium typically, and it's gotten worse with a reduced intake of dairy. And so, the ability to combine both the diet and the supplemental intake of something like calcium or magnesium, any of the nutrients really, does present a different picture and does appear to have, and again, these are just preliminary data right now, but appear to have different associations with something like blood pressure. So, again, it's a question of getting a better and perhaps fuller appreciation of the overall biological impact of the combined intake, whereas the diet data help us in terms of understanding preventive dietary recommendations and, pointing out the food sources of those nutrients that are being omitted or being ignored or under consumed and things of that sort. So again, as we anticipate what will be forthcoming in terms of precision nutrition and the biomarkers that help us understand more completely the bigger picture, I think we will become increasingly aware, and the need will be important because, as we all know, all nutrients are synergistic. And so, if we're creating an excess intake of one nutrient, it could actually be creating a deficiency in another. So, and I've seen this myself in terms of some of our data related to iron and zinc, for example. So anyway, I think it's a very important and increasingly important area of documentation as we continue to try to put all these factors together.
Anna Maria, to add to that, I think we can go back to your previous question of, what are our opportunities here? And so maybe our methods are not all or nothing. Maybe they're not all checklists or just add them to the other. Maybe it's a photo assist or a text assist that allows the participant to do something pretty quick. Smartphones are pretty pervasive now, that allows them to hand you the information in real time, and then you can ask some follow-up questions about it. So I'm encouraging thinking outside the box in this of how can we merge our methods together to get better at collecting just these kind of data.
Okay. Erica, I see you have a question.
Yeah, I want to just step off from that really important comment about the photos of the food and the real time. I think that's a great recommendation. And I just am curious about emerging these methodologies. There seems, maybe just comment on the day-to-day variability of the dietary intake in toddlers and how much is it much greater than other age groups? And then how many days of either these 24-hour recalls or these combined photographic methods would be ideal to get a really good picture of the dietary intake of toddlers? And I'll let anybody address that.
So I think that kind of question of, the how many measures and what's being provided for them is, I think, relevant for both the dietary and the supplement questions. Mm-hmm. And I think that, we just need to be able to, get a better handle on those. And that may require some of the kind of more extensive kind of, things, because we know that there are advantages and disadvantages. They were laid out well today of both the questionnaire and the 24-hour recall. And kind of thinking creatively about what parts of that are being measured, kind of celebrations, other kinds of things, as that overall kind of pattern, as well as the social desirability bias issues that we've talked about. And, I think that's where kind of this little sub-studies in terms of these larger studies are going to, I think, provide a lot of information to that, particularly, again, around supplements that I don't think have been well studied. We have a whole medication adherence kind of literature, but this is different.
And Erica, if nothing else, this is Linda, the fact is, we know there are tremendous differences between weekends and weekdays.
Yeah.
I can tell you in the city of Chicago, probably 100% of our population eats pizza on Friday night. I mean, it's just what happens. You can expect it. So, but I think, that's where, you begin to see that there really are differences day to day. And again, as was just pointed out, the supplements probably differ over the weekends too. But point being, having some extent of intake over a period of time is definitely a valuable component.
And just, Anna, again, the variation in that young child's diet, I do think is much more profound than in an adult as they're establishing. So I think it's a great question, Erica. And we had this national study, we did the best we could with that usual intake estimate on 25%, but I would imagine that introduction, especially those youngest ones, as they're establishing their taste preferences and you're trying to reintroduce over and over, there probably is a lot more variability than we would expect in our older populations.
Thank you.
Donna, I'm not going to be able to get your question because we're at time and I need to hand this over to Cheryl. But I want to thank all the panelists today. You gave us a lot to think about and such a wonderful presentation. So thank you so much.
Thank you very much, Ana Maria. A wonderfully facilitated conversation. I'm going to go ahead and share my screen now just to present a few summary points. So first, I'd like to thank our speakers for today, Drs. Susan Johnson, Linda Van Horn, Andrea Aniter, and Nick Horton. This was indeed a very insightful and rich discussion. A few of the take-home points, we talked about how really this is the stage of life where food preferences get established, and these are habits that are likely to affect health across the life course. And so thinking about it never being too early to get started in getting the right assessment tools is important here. We really dove in on the need for multiple informants, proxies to give information given the cognitive limitations in this age group. And this may actually contribute to some measurement error and missing data. And we talked a little bit about how we might use various statistical techniques to account for that. Every bite counts. I really like that perspective from our current dietary guidelines for Americans, and appreciated us diving into the evolving market of foods and beverages around what toddlers consume right now, and how important it is in our assessment approaches to have the flexibility to be able to enhance food databases so that we're capturing some of those real-time changes in the market. No tool is ideal. It doesn't matter, what stage of life we're doing assessments for. We really need to think about what is the research question that we're trying to answer, and how do we match best to that question with all of the practical considerations. So our choices are going to depend on the kind of effort that we can put into assessment, the amount of resources that we have, whether that's time, budget, and the demographic profiles that we are experiencing with our study participants. I loved the part of the discussion around considering, merging our tools to really from an analytic perspective, gain some benefit, as well as from the assessment perspective, gain some benefits, and the potential for telenutrition or us utilizing some of these more emerging technologies in our work. I want to just reiterate the point that was made around the digital divide. And in doing this kind of merge or inclusion of these new and emerging methods, that we don't leave any of our populations behind, and that we are truly approaching it in a way that's inclusive, because not everyone's going to have, access to the kind of bandwidth needed to make these things happen all the time. And then one of the, I think, continuing points, no matter what stage of life we look in, is that keeping our eye on the ultimate goal. And often, in addition to us doing research and trying to get at that question, we're often wanting to provide insight into nutrient status in this age group. And so our dietary assessment methods, no matter what route we go, how well we create a package that might help complement what we're trying to assess, we should also not lose sight of the fact that we do need to have metabolic status assessed so that we can really get a handle on a better picture of nutrient status. So with those take-home points, I want to invite you back to our next webinar, which will be in 2 days, Wednesday, May 19th. We will continue our conversations around dietary assessment, this time in children aged 6 to 11 years. So thank you so much for being with us this morning. And at this time, I will stop sharing and adjourn our webinar and say, hoping to see you on Wednesday, and please have a great week.